with that in mind and shared, it's time to introduce our speakers. So we've got some pretty great folks, and I'll just dig into it here. We have Dr. Marianne Curl. She's been the Chief Medical Officer at the Washington State Department of Corrections since March of 2022. Her top priorities as CMO are inspiring staff to follow an ownership culture, transforming DOC healthcare to a vibrant, proactive continuum of care by creating the DOC patient-centered medical home and implementing an electronic health record. So lean practices are a vital part of Dr. Curl's transformation plan. We have Kathy Renninger. Kathy is the Senior Health Systems Manager at the Washington Corrections Center. She's worked in private corrections and the Washington Department of Corrections in a custody capacity, as well as in health services for 26 years, providing valuable crossover knowledge between the disciplines represented in a corrections environment. Kathy's commitment to excellence led her to earn a master's degree in psychology and the prestigious title of Lean Six Sigma Black Belt. Patricia Patterson is with us as well, and has been a nurse for 20 years, beginning her career in the emergency room and operating room. Patricia became a sexual assault nurse examiner in 2008. She helped develop the same program at Grace Harbor Community Hospital, and in 2020 Patricia was hired as an RN3 at Stafford Creek Corrections Center, transferring to Washington Corrections Center in 2011, where she worked as an RN3 and now as the RN4. Patricia received her certification in correctional health nursing from the NCCHC in 2022. That's wonderful. And finally, we have Scott Svoboda. Scott has held numerous positions in DOC and brings over 28 years of professional experience. Scott started at the Washington Corrections Center in 1995 as a correctional officer, and he moved on to the correctional unit supervisor at the Washington Corrections Center for Women, correctional captain at the Washington Center for Women, and then captain at WCC, managing custody and security operations. After 2 years as captain, he moved into the role of correctional program manager over the reception and diagnostic center. So we've got a lot of great expertise here, and we're really glad to have you all. At this point, I'm gonna let you all share your materials on screen and hand it off to Dr. Curl.
Let's see, Patty, I was kind of thinking, okay, good. Hi, I'm Marianne Curl. I'm the Chief Medical Officer for the Washington Department of Corrections. Okay. And excuse me, I am extremely excited about the team that's presenting with me today. I kind of told them that they were going to present, and they have worked really, really hard to build a presentation that tells our story just exceptionally well. And I hope that you will find it inspiring. And I hope that you will find one little nugget that you can take into your workplace and leverage for improving your work. Some of the things that we all share in common is that we have things that come into our lives that feel like they're just too heavy and that we can't possibly change them. One of those things for us was a backlog of patients that would, or incarcerated persons that would come in from the various jails and need to get their initial physical and their initial classification so that they could move from the reception center into the rest of the state where they were going to be for a longer period of time. And it seemed like no matter what we did, we could never keep up. When I was working as a locums in the Department of Corrections, I would go over on Saturdays and help do physicals and try to catch up. And it felt like it was something that we were always chasing the possibility of catching up someday. And so I hope you enjoy this story. I absolutely adore these people who are telling you the story, and I hope you'll enjoy listening to them. With that, I will pass it off to Kathy.
Good morning, everybody. This is Patty Patterson. I am having some technical difficulties, so I have no speaker's notes, so we're going to be winging this. But I know the story because I've lived it for the last several years. Washington Correction Center, or WCC, as you'll hear throughout this presentation, is the diagnostic and reception center for all men that are sentenced to a year and a day or more to prisons here in Washington State. And so we receive about an average of 150 men a week that are new to DOC. When they get to WCC, they have to go through what we call classification. Are they a maximum security individual? Are they medium custody? Are they minimum custody? We do complete their physical, which is dental, infection control, their medical physical. They go through a mental health assessment, and they get all these codes and numbers placed on their file that pretty much directs where they should spend the majority of their sentence. There's also things that the judges order, parenting classes, drug treatment. So the different things that the courts order are also taken into consideration, and they're moved to their parent facility. All of this is supposed to happen within around 30 days. Physicals by DOC policy are to be completed within 14 days, and that was not happening. The physicals, they got backlogged during COVID because we had so many systems in place to keep the spread of COVID down as much as possible. We were very lucky in that we had very few admissions to the hospital during the entire COVID pandemic, but that backed up everything. So our physicals that we try to complete, like 35 physicals a day, got down to 1 or 2, just because people were either in quarantine, or they were sick, or they were next to somebody who was sick, or staff were getting sick. We were trying everything we could to catch up. As Dr. Kroll mentioned, we would get strike teams scheduled to come in and do nothing but physicals, but then 1 or 2 people would come down with COVID, and that plan would fall. We had gotten permission from the governor to reduce, and then for a few weeks actually stop people from coming into the prison system, just so we could try to catch up. There were people sleeping on the floors. We were just falling further and further behind. We attempted to modify the patient flow in our clinic. WCC is an old building. It was built in the 1960s, and trying to repurpose rooms and areas in the clinic to make patient flow go more quickly. While it did help improve, it just wasn't enough to get caught up. So the time from admission to when we were actually getting physicals completed was on average 4 months. We had some outliers that were actually waiting up to 6 months to get their physical completed. So what we started with at WCC, as I said, was this older building. We have different sections for dental, medical, mental health, infection control. So patients were coming up from their units. They would go to a waiting room, be ushered to another room to get something completed, go back to the waiting room, be ushered to another room to get the next thing completed. And it was all this back and forth. And it was just not utilizing the space well, and it was certainly not helping our patients get through the system. We had tried changing rooms around and changing where healthcare workers were stationed, hoping that would improve, but in the end, we still were too far behind. When the COVID restrictions were starting to go away, we weren't as restricted as we were. Movement of individuals from their units to the medical clinic and to other areas of the prison had loosened up. We also had the ability to repurpose infrastructure that was put in place for the COVID pandemic and use that those materials and resources for other needs. So Kathy Renninger came to WCC and immediately saw that there was a way to get through this backlog. She asked if we could repurpose one of the tents as an addition to the infirmary. She worked with staff to get supplies ordered, working with staff to figure out what all would be needed to set up the second clinic. And so that's what we did. She worked with maintenance, custody, and everybody else to make sure that we were able to provide a safe environment for staff and patients, and to get this backlog reduced. So once Kathy was able to get the tent moved and erected next to the infirmary and get everything in place, by that time we were into the patient-centered medical home process, and we were able to use the concepts from that process and use all the information from the different staff members that were going through doing Gemba walks and really looking at how we did everything. They went over to the tent and realized that there were improvements that could be made over in the tent. So working together, we improved the patient flow. They opened up the area of the tent, standardized the work areas, reconfigured how we had the tent set up, and improved how much time was spent out there. Further work in the PCMH model suggested we get a second provider out there. That helped immensely as well. Now that caused staff to have to figure out how to work with less providers in the clinic, which they were able to do because there was so much improvement with patient flow that our providers were actually able to spend more time with patients and see more patients. So with the change of the flow in the tent, we were able to start reducing that backlog. This slide just shows some of the staff going through the tent with the original setup and bringing suggestions on how better to move things around and create that better patient flow that allowed the providers to see more patients and allowed staff to get more work done. The slide represents just the data that was gathered during these Gemba walks, and what was needed in order to change. This shows how we were able to increase the number of patients we were seeing by adding that second team of provider and MA and changing the structure of the tent. They also decided that if we split the patients up between those who are complex, so those patients who, are older, take more medication, have more chronic disease, keep them in the infirmary and have their physicals done in the infirmary, and just have the non-complex patients, the healthier young men without all these chronic conditions, have them go in the tent. They were able to increase up to 40 physicals a day, which is that's fantastic. So that really met the need. And then Kathy, I believe it is your turn.
You're on mute, Kathy.
Sorry about that. Good morning, everyone. As Patty stated, we did time studies, and here's an example of one that we had done in the tent, of all the steps that it takes for the incarcerant to move through the tent. Our eye exam is first, vital signs, a waiting period, to the provider for the physical, weight, lab if needed, and then we'll move back to the unit. So when we talk about movement back to the unit, we have an officer in the tent who will walk over to the living unit in the morning and bring back 5 incarcerants for their physical. And after they are all completed, he will walk them back to their unit, and he will take 5 more and bring them back to the tent. So that is what we consider when we talk about movement through this process. The other is our flow of what it would look like as the incarcerant went through the tent. So we observed waste. The waste observed had prohibited us from being able to achieve movement measures we were trying to implement using the PCMH model. So on day 1, as you can see, there was quite a bit of waiting going, for the incarcerant. Our skills were the providers spent time correcting forms, and they passed, and unfortunately, we passed this waste on to, I'm sorry, it wasn't a waste, it was a defect. Passed it on to the provider when we realized that the medical assistants who were working in the tent and taking the vitals could work with the incarcerants and help them fill out those first 4 pages by highlighting the areas that they needed to fill out and explaining some of the questions that were there. And what that did was it improved the provider time, because the time the provider would have spent filling out those 4 pages and then his 4 pages or his or her 4 pages took quite a while. And that's why sometimes we had 20 to 30 minutes per physical. So we identified a waste is the movement of the incarcerated individual from the living unit to the tent. We haven't figured out a way to overcome that waste, because I think it's just a product of where the living unit is in relation to the tent. So this is a spaghetti diagram for all of you lean aficionados. I'm sure you will recognize this. So our first layout shows that the tent is tubular, like you saw. And so we split it up into 2 sides, one side being the officer's booth, 2 provider areas, and then, I'm sorry, not a provider area, a supply area, a provider, and then another exam area. Then we had on the other side, we had the waiting room, we had vital signs, we had the lab, and instead of an exam room, we had storage. So we put both providers on one side and then the vitals and the lab on the other side. So after some observations and time studies, we switched things around a bit, and we still had the officer booth and only 2 providers on one side. We had the waiting room, vital signs, labs, and storage on the opposite side. Still a bit more walking than we really wanted. And then finally, we moved things around again in the tent after another time study. And we moved the officer over to in front of the waiting area. And then we had vital signs and storage on one side. We moved the lab up to where the entrance is. And then we had the 2 providers. So the incarcerated individual went from the waiting room to vitals to the provider to lab and then back to the waiting room. And so this really did increase the flow of the tent, and we just had more time again for the providers to do their to do the physical and also to do charting when necessary. So this is the tent layout after. You can see the blue chair in the corner, and then you see the desk. That's the officer's area, and then the screen behind that is where the vital signs are taken, and then the incarcerant steps out, and we have the eye chart on the very back door so that they can complete their physical. The provider area has a desk and an exam table and is separated by a screen, so both of the providers have privacy while they're doing their physicals. Our lab consists of a phlebotomy table, and then all our lab supplies and a computer for the MA to do his or her documentation. Our vital signs, we do blood pressure, height, and weight, and then they step out, and then they look to the end of the tent, and they look at the eye chart. The waiting area, as you can see, has the incarcerant's chairs and the provider and the officer waiting area. Our patient have various levels of reading proficiency, and we need complete and accurate information when we're going to provide care. The MAs are there to assist the patients in filling out their paperwork, and again, it eliminates provider time spent on the forms. So in April, we were at 16 minutes, and then by June, we were at 3 minutes spent on the forms. So this is just a depiction of what everything was before and when they went to the tent, and we had a lot of waiting time. And then after we did our time studies, or after we realized that very often the incarcerants will go to dental first to get the dental part of their exam, and that was a great time to work on their prep forms. And so we took that out of the tent. There are times when, if the incarcerants don't get to the tent, don't get to dental first, they will do it in the tent. But again, it's still very, it works, and it doesn't take time away from the providers. So day one, they prep forms while they're waiting for their dental visit. Then they'll travel to the clinic. They'll wait to have their vital signs. They'll wait to see the physical, the provider. They'll wait for the lab, and then they'll wait to be walked back to the unit, which is very time effective. So one of the things we looked at when calculating the target date to eliminate the backlog is that we realized we had 14,400 minutes within an 8-week period to do physicals. We divided that demand by 700 physicals, and that equals 21 minutes per physical. So we used 15 minutes for non-complex physicals. The non-complex would be individuals who maybe have one medical problem and no comorbidities, maybe one medication, and are basically very healthy, versus a complex physical, which is somebody who has chronic care conditions and is on different types of medications and requires more time to discuss these things with the provider. So our PDCA cycles are plan, do, check, act. Plan is to determine goals for process and needed changes to achieve them. Do, implement the changes. Check, evaluate the terms, evaluate the results in terms of performance, and act, standardize and stabilize the change, and begin the cycle again depending on the results. So when we started with because WCC was phase 3 of the PCMH process, we do these check-ins every Tuesday. And we tell them what process and condition we are working towards, what our actual condition is now, and what did we do what did we plan for our last step? And we would often write down our cycle, what were our next steps and what did we expect and what were we measuring and what did we want to achieve. So we do this every Tuesday, and I have several representatives in the clinic that will talk about, I will talk about backlogs and clinic flow, and we have other people that will talk about other things that we're running through as part of PCMH. We also, when we do our PDCA, we talk about our tests, we talk about improvements, and then we talk about obstacles. So let's say that with the clinic flow visit, it's been green for several weeks, and then we need some more computers, or we need to have data drops to put in a network printer, and that there is a lag in that. It might take us from green to yellow. So this is our data showing what our backlog looked like. So the orange are the number of physicals needed. Okay. So we were at the most at that time in April of 24, we had 800, let me see. Yeah, 860 physicals, or 880. That's really small. I can't read it. But the orange shows the number of physicals needed and how every month when we gather data, how we went through that and how small that orange part became, because yes is orange and waiting for a physical, and no is blue for physicals needed. And then when we look at the count of physicals by due date, the gold part represents physicals that are overdue, which we had 775, and due within 114 days was 105. And as you can see, that gold part went down significantly into June, and we have kept it very, very low. And our blue is due within 14 days. And I think as of last week, we were getting physicals done within 5 days of arrival. And now I'm going to hand it off to Scott.
Hello, everybody. One thing I would like to say is that I've been part of some lean processes in the past. I've never seen as many tools used as were used in this process. And it was a wonderful learning experience. So, and to see the improvements that happened, as Kathy was saying, in the tent, by doing those spaghetti diagrams, timing how long things took, rearranging the tent. I was pleasantly surprised that when we first started doing it, there was like, we might have done 20 physicals in there. And after Kathy suggested the movement of the tent around, by the end of the day, we had an hour left where we could put more patients in there. So it was crazy to see the improvements. So when you talk about custody and medical working together, that can be, we have lots of barriers there sometimes, because as medical has, you know, the patient's patient-orientated treatment on the prison or the custody and security side, we have to consider when we're doing all these movements, when we're bringing these people to the infirmary, doing the classification, that we're also considering people's safety and the security of the facility. So at the Washington Correction Center, we currently, we're in the business of moving people. It is where they get their initial classification. As Kathy and Patty were saying, one of the key elements to that is we have to have the physical evaluations, medical evaluations, mental health evaluations before we can complete any of the other classification, because that has a big determination on what parent facility they may be able to go to, because that parent facility is, each parent facility has different resources at their fingertips, to include medical, mental health, all of that. So with that, we have 6 receiving units due to the amount individuals we've been able to put through the physicals and complete the classification. We've actually been able to completely empty one out and going to make it another living unit for more workers in the facility. Plus, each one of our units stay below the maximum capacity. So let's see, to individuals at their parent facilitation. So those of you that don't work in a prison, classification is determined by criminal history, which kind of determines the custody level and the security needs around that, physical limitations, medical treatments needed, time and sentence structure, amongst many other things, in order to get them classified. Currently, we kind of have about an average of 100 per week. And as Kathy was saying in the beginning, and Patty, about the physicals only getting 12 or so done a day wasn't meeting our needs, because we get at least 100 people a week. And that's probably, under averaging how many we actually get. The receiving facility has limited programming, so that's why we want to move them through. They don't get the yards. It's considered closed custody. So if we have people in medium custody or minimum custody, the object is to get them moved through, because we want to get them to a parent facility to where we can get them into treatments, get them back into reentry programs, and anything that we can do to help them become more productive members of society once they're released. So the completed, let's see, the partnership between custody and medical, which I know they'll all attest to, is an ongoing battle sometimes, because we both have, different goals that we're trying to meet. However, I think that we've done a wonderful job of working together. As Patty was saying, we have an officer designated to bring individuals up to the tent, which, when you look at 6 units, each one of them have to be kept separate, because we have what they call STGs, which are security threat groups, which would be gang activity. We have a lot of violence, a lot of fighting. And by this graph you're looking at here, if you look in the year of 2022, those spikes are from COVID, when we went on to restricted movements, when we were completely on pretty much a complete lockdown. You can see in the next year, January, February, and March. March is when we first opened the tent. The amount of physicals that went through, we were able to get tons of people out of the facility, keep them moving. Because when they're limited to 30 days versus 3 months to 6 months, they don't have time to organize. They don't have time to develop, in the gang activity. They have less opportunities to fight with each other, and their mentality at the receiving center is different than at the parent facility, where they have all the programming and they have all the amenities. So the quicker we get them through, the safer it is for everyone, to include them. You can see on that uptick, the tent did close for a little while. The violence increased and then finally decreased again drastically, where it's maintained. Some of these benefits that happen when we get these individuals through the facility that I knew I would see. I didn't think I would see it so quickly, but it was pretty immediate after all of this was put into place and the physicals started moving, and we were down to 30 to 45 days of getting individuals out. Was, of course, you have a reduced demand on workloads when you're showering individuals in the units, reduced mealtime kind of things, lowered living unit operational costs, because when you think about the individuals in the units, when we have floor sleepers, it causes overtime, because the union regulates that we have to have another staff member in the unit for safety and security. The cost of toilet paper, cost of running showers, cost of food. With us keeping, I think our units now, we typically have at least one open tier, which drops the population in each of the units by 30 to 60 individuals. It increases the morale of our staff because they actually have a manageable workload, less violence, and less gang activity. As we get into this particular graphs show physicals exams from 62 days down to 16 days, which I never thought I would see it drop that fast. And so the benefits of that is once the physical exams are done, medical pieces are done, now we can complete all the rest of the classification. And typically we're getting people out of there within 45 days. The goal is 30 days, which I'm absolutely sure we'll meet. The average days between admission to transfer, you can see how it went from 81 days and took a drastic plunge down there. And it stayed down. There was a little uptick back in April when it closed, and it just really shows the effectiveness of the tent and getting the physicals done within those time frames. When you talk about the impacts of the lean process on the prison, the transfer out graph there shows how many we were actually transferring out. So we hit a peak of 702 in March when that tent opened. When it closed through the end of March and didn't reopen until April, you can see transfers out dropped to 516. Once it was reopened, it was back up at 797, which really meets our goals of moving these individuals out to their parent facilities to get them into programming, learning, education, re-entry, getting them connected back to their families. So you can see also in that one, the average daily population, how it's dropped. And so if you can imagine, the dangerous situations that can be caused, by intermixing all these people, medical and custody working together is extremely important because we have 6 units that we have to keep separate, plus a working population. And it can be very difficult to manage all that and keep everything separate and keep everything moving. And I think with that, reduced workload, showers. I mean, I can't tell you enough how as a prison administrator, I'm on call, to give you an example, once a week, 24/7. And my calls went from 5 to 7 calls a day, if not more, down to I had 3 1 week in a whole week. And I had to actually call the facility and go, are you guys okay? Is everything going? But that shows the results of all this work that's been done and how those lean processes have worked and how it's affected us on the custody and the prison side. I mean, it's all about us working together to get people through and reduce all the violence and the floor sleepers and the cost. So if you go to the next slide, I thought there was one on the costs, though, some of the costs in there. So I'm sorry, that was in the bullet points in there, but we do have, we reduce an average reduction. Now this, I was very generous with this. I could have went way higher probably, but we've reduced a reduction of 253 individuals on the average in our population. And up there is what it costs to house an individual for 30 days. So, it's approximately 4,868. So with that reduction, it's it equals a cost avoidance of 1.2 million per month, which I thought was crazy. I had to have people look at it because I was like, oh, there's no way we could have saved that much money. But it was, it's been a great experience working through this, and I'm sure it will be ongoing and we'll constantly be making changes to it. So I think that is all I got. You got something to wrap up?
Move it to the last one. That's great. So things you might have heard, we had a supply-demand mismatch. We analyzed the flow and the throughput, and we continued to do PDCA, Plan, Do, Check, Act cycles until we got it right. As you could see by Kathy's slide on the flow through the tent. There was a good breakthrough on getting a linear progression through the tent rather than the back and forth flow that we had before. One of the big things that we did was we separated out the non-complex physicals from the complex physicals. The complex physicals are people that have more medical issues and may need a little bit more time, and they take about 30 minutes. By doing that and emphasizing the throughput, we were able to save about 10 minutes per person if you average it out, because the non-complex are about 2/3 of the workload and the complex are about 1/3. And that gives you 6.7 hours per day back. And we obviously can use that to improve what we're doing in terms of connection, get our paperwork done, those kind of things. And it's obviously valuable. The tent was a huge breakthrough because it helped us have some more flexible thinking when you're dealing with the walls of an old building and the constraints of the flow in an old building. It just, you aren't as creative. And I have to give Kathy Renninger props on that one, because she had the idea of the tent, and that I think was really the breakthrough that enabled us to just think differently. And as you can see, these are people who are highly collaborative and care about each other, and they care about the people that we're serving. And I have to give props to the whole team, because you guys were the leaders that help to affect and influence everyone else around you to really engage in the workshops. So we had ideas of things we wanted to do, and we leveraged the fact that we had PCMH workshops to test things and to grab people from other sites and do the timing and kind of use the tools and learn them. But you guys were the leaders that made that happen. So props to you. DOC is super proud of this team, and we're grateful to our lean consultants. We've been working with Moss Adams. We're grateful to Candy Tribbett, who's been our project manager and has really helped to put this presentation together today, because we wanted to tell you guys a really, really great story. And I'm so proud of our team today for bringing out the just amazing story of what you've done this last year at Shelton. And fantastic job. I see some questions. One is, what are the workshops, first, second, and third, that are referenced on Kathy's last slide? And those were the lean transformation workshops that we did for patient-centered medical home. And we had care design goals that we met and worked on together. And we were able to leverage people coming from all over the state to work with the Shelton team, who had great ideas of how to use them. And I have to say, if they hadn't had great ideas with how to use them, then it would not have been this effective, but they were amazing. What was the turnaround time for reconfiguring the tent, and how did that time cost impact your decision making about trying new layouts? So Kathy, do you want to answer that one?
Sure.
What the turnaround time?
Sure. We, I think it took probably about a month because we had several tents. They were called an RDCF, and they were used for COVID, because if our inpatient unit became full, we could bring patients in there, because the tent is climate controlled. But it also ran off generators and diesel fuel. So when we asked if they could move the tent between reception and the medical building, they moved it. Their idea was to move it in exactly that spot across from the power grid. And then it took a little bit for them to run the power under the tent so that we could have electricity and air conditioning and heating and computers and internet access. and we were not dependent on generators. So with everything that went on there, ordering the supplies, getting everything set up, and I have to give major kudos to my administrative assistant, Ashley Fowler, who was the individual who I would just go in there and look at the end of the day and see what happened. But she just worked like she was our angel. She just did everything, and it was absolutely excellent. So I would say about a month or a month and a half. And before we started, we did start seeing the patients in there at the end of February into March. And as you could see by the spikes that Scott talked about, and then we had to close down for a bit because we had some staffing issues. But all the time, we still were getting supplies in there and getting desks in there and just getting things. So it was a work in progress. I would say easily 3 months, but we started using the tent well before we had everything in there that we needed, because it was just a work in progress. And then when we started with PCMH, we saw more improvements we could make. So
one of the things, Kathy, that you guys did kind of as a result of looking at the flow through is you changed actually the initial reception space for some of the screenings for dental and mental health and for the nursing screenings.
yes.
So that became a more linear space for people. Do you want to maybe spend a minute telling about that piece of it? And then also there's a really good question that I think would be really great if you would answer to you, Patty, Scott, all the staff. Were they resistant at first? And then what did you do to win them over?
Well, I'll answer that one first. Our staff was not resistant. It's not that they were climbing all over each other to work in the tent, but we did have a blue badge who worked in the tent, and because we were really we were rotating our staff through, and we also had a contractor that was in there every day, or 410s, and they all really like it. But when they work in the tent, then their panel of patients that they see in the clinic wait because they're in the tent doing physicals. So now we have this individual has moved into the tent, this blue badge individual, and we've hired another person to take over his panel. And then we have a contract staff who's in there works, but we did not get any pushback as far as the tent, because it really took the burden off of staff. Because when we were doing these, what we call strike teams, we would ask providers to come in on the weekends to see patients and just to do nothing but physicals. But what that resulted in is, exchange time. So they might come in on the weekend to see patients, and then somewhere down the line, they might want to take a day or two of exchange time, and then we don't have them in the clinic and no patients are seen. So they liked the idea. They were very receptive. They gave very good feedback. And it's the providers in the tent that gave us quite a bit of feedback, as well as the medical assistant in the tent, as to some things that were needed. The officer gave really great feedback about movement and about what their needs are. And I mean, as far as, where to move their desk, or, can they have a refrigerator? Can they have a microwave? We couldn't give them a bathroom, unfortunately, but just things that are kind of like creature comforts that we all take for granted because we're in a clinic and they didn't have that. What else did you ask me, Marianne?
I think we got all the questions answered that were in the Q&A box. I typed a few things while you were talking.
Okay.
And I think we got those answered. We would certainly be open to any other questions that anyone has, but I think we're kind of running toward the end of our time here, believe it or not.
Yeah, it flew by, right, gang? So
it flies by.
Thank you so much. This is fantastic. I think, a lot of the vibe in the Q&A and all of that, and some messages on the side is there, what were some of the lessons learned, or was there something you would have done a little bit differently looking back? I know, Scott, you shared like this was a project where you used the most amount of tools out of all the past projects. And so I don't know, was there a tool that was a little harder for folks to wrap their heads around or to deploy in this situation? Or what's sort of a in retrospect moment for you all?
I would say the probably the timekeeping, because we did this through when Moss Adams was out at the facility, and we had started phase 3 of PCMH. And then when they left, the expectation maintains that we will do these time observations, both in the tent, in mental health, and in medical. And it kind of coincides with the reception process project that we're working on. So PCMH and the reception process are really working hand in hand, and the improvements through the reception process have positively affected PCMH and vice versa. So I think the most difficult thing for our providers is asking them if they will, because there are certain time observations that we can't get that they can get. And I think part of it is, when they do their charting, how long does their charting take? How much time do they spend on the computer? So yeah, that is that's I think that was the most difficult tool that
I
they used.
was shocked by it, because I was a little bit of a naysayer when they said, oh, well, you can cut 3 seconds here or 10 seconds there. But when you look at timing, charting that out, looking at the spaghetti diagram about how much the person was running, how much time it took, it was amazing how much time we got at the end of the day, and how those seconds, I would say, keep your mind open to the tools. Because
Right.
it does cut a lot of time down. And you would think 10 seconds here, 15 seconds there, 30 seconds there, it saved hours at the end of the day. I was shocked. It was a good experience.
Yeah, that's a great reminder, right? When we're talking about huge input and outflow, it adds up, and the results you all met were quite impressive. So thank you for sharing that with us. Thank you for being here.